So we laid the foundation for some of the concepts that we're going to go through during the last hour. How many in the room have been asked to participate in something outside of simply running an emergency department as part of a relationship with their hospital? Observation, hospitalist, urgent care, wound care, hyperbarics, telemedicine. So within the constraints of 30 minutes, I picked 2 that seemed very relatable and had clear reimbursement pathways. All of the ones that I mentioned are part of the forefront of our growing specialty. And again, our future is dependent on moving past this concept of I'm going to be taking care of the patients that exist in my 4 walls, because those patients will change. Those lower acuity patients, if we look at the E&M distribution, if we look at the ICD-10 discharge codes, those lower acuity patients, based on all the pressures that we talked about in the prior hour, they're going to be seen somewhere else over time. They will likely be seen in an urgent care or via some sort of mobile app. We're getting there. We're still getting there. Chris, help me out. Thank you. All right. We're going to go through 2 different case studies. They're both real. 45-year-old ED physician working in a level 1 trauma center for 15 years. Maybe he's got a little burnout, but he's not depressed yet. Has entrepreneurial spirit, is looking for extra revenue, spends $10,000, not that much, on consultants to find an urgent care site with an optimal payer mix using some demographic predictors. $600,000, so there's the big risk component on the build out. Negotiates some payer contracts, hires a few part-timers. 2 years later, he's working 2 to 3 days a week in the urgent care. He's dropped his ED shifts down to about 6 shifts a month, and that urgent care is profitable. 2-3 years, common level of profitability where you've paid off your ramp-up and your startup costs, and you're moving along $350,000, a robust ED doc salary in profit per year. He says, well, I'm going to take that profit, I'm going to roll it back into the business and open 2 more urgent cares. Those are working well. I'm going to take that profit, plow it back into the business. Now I'm 5 years in, it's a true story, operating 7 sites. And now we're ready for what's called a capital event. That means I take all the hard work and bundle it up and see if somebody else will pay me a lot of money for it. 10, 12, 15 million bucks, 7 urgent care centers. There wasn't any match. This is just a hardworking guy with some vision who is willing to take the risk and diversify. It's the most obvious growth area because of all of the economic pressures. Low acuity patients, in 5 years, they're not going to be in most of our emergency departments, but we are the masters of acute care. We can still own those patients. We're just going to own them in a different site. And it could be that we're an independent group and we're opening urgent cares. Could be that we're independent and entrepreneurial individuals opening urgent cares. Could be that we're a big giant group associated with a hospital going through a joint venture. Here are the top urgent care operators, and this list actually has changed a lot in the last 5 years. Concerta, 294 sites. MedExpress, 200 sites. NextCare, 136. Patient First, big in the Mid-Atlantic area, 74 sites. And CityMD, relatively young, 69 sites. Combination of owned entirely by that enterprise, joint ventures with a hospital. And as we look at some of the transactions that are starting to take place, we're increasingly going to see insurance companies owning these urgent cares. Let's look at some of the growth. 10,000 urgent cares in the United States. Only 4,000 emergency departments. 10,000 urgent cares. 294 mean patient visits per week. That's 42 patients per week. 42 patients per day. And that data is a little bit skewed because you need 22 to 25 patients to break even. Volume is the absolute threshold to profitability in the urgent care market. If you build an urgent care and get some decent contracts, if the patients come, you make money. If the patients don't come, you've got all this fixed cost, you lose money and you close your doors pretty quickly. 294 is sort of on the high side because there are a lot of urgent cares that are operated, let's say, patient first. They might see 250 patients in a day, so that data is a little skewed. 40%, 4 out of 10, are expanding and adding new sites. 27% is the typical revenue growth of successful urgent cares over the last 5 years. Half of them are freestanding on their own. Half of them are part of sort of larger medical complexes. One of my buddies, who's very entrepreneurial, who's in the group that I started, has opened up his own urgent care. He has an urgent care. He has a dry cleaner as a tenant and a Chick-fil-A. I don't know. He's making it work. What can I tell you? 69% had a wait time of less than 20 minutes. And then we looked at that growth of high deductible health plans and that enormous growth in health savings accounts. And now the consumer is at the crux of our pricing issues. Look at the difference in prices. 3 low acuity conditions, so ankle sprain, conjunctivitis, and otitis media, ED average payment, average out-of-pocket required dollars to be spent. So not gross, not net, not out-of-network, just what the patient was, in the end, had to write a check for, $550. Primary care physician, $160, urgent care, $150. $550, wow. We'd all be retiring, right? Otitis media, conjunctivitis, 70% of that money, that's the facility charge. The ED component of that is like $150, $120, $130. ER copays absolutely ramping up. If anybody has an insurance card in their wallet right now and you turn it over, and if it's got copay information, it'll now differentiate primary care physician, specialist, urgent care might be $50, ER, $150, $250, $400. And why is that? The insurance companies want to avoid specifically the very expensive facility fee. The ERs aren't expensive because of the emergency physicians. They're expensive because they're in a hospital where we are ready with the fixed cost, the standby cost, to take care of. How many delivered a baby in their ER in the last year? Deliver a baby? Yeah. How many opened the chest from a gunshot wound in the last year? I see a pattern of the same hands. How many took care of a whole lot of sore throats and flu? Okay. So let's see. Anyone with anything at any time. There's no other vocation that is willing to put themselves in the line of fire for that, and we've got all of the standby costs. So yeah, not surprisingly, it's sort of expensive. If I can take care of a family of 4 and roll over MVA, and oh yeah, I need all the stuff to do that, but then I also need to quickly process the conjunctivitis patient, the standby cost and the fixed costs of our hospitals are enormous. There's a lot of low-hanging fruit, there's a lot of work, and everybody here is involved with trying to make their hospitals more efficient. But there are some basic differences between why we will never be able to compete with the urgent cares on cost associated with these lowest acuity patients unless we stop making ourselves available for the highest acuity patients, which is truly our passion and job calling. And the urgent cares are very profitable. The median physician comp based on last year's survey, $175,000. And they are starting now to get very big and recruit our mid-level providers. So a lot of groups have actual staffing issues on the ED side because the urgent cares are gobbling up talented emergency providers. Here are some noteworthy transactions because the urgent care community grew a lot in the 80s, and there were a bunch of sales, and now we're seeing sort of this bimodal process where they grew starting maybe in 2008, 2010, 2015. United Healthcare purchased 141 MedExpress sites. United Healthcare. Wait a second, that's an insurance company. You betcha. United Healthcare takes on risk. So they now are going to own the urgent care and very forcefully direct patients in that area. $1.5 billion. Humana buys an interest in Concerta, $1 billion. Northwell, anyone here from the Northwell system? Big giant system in New York? Very entrepreneurial, has tried their hand at operating their own community insurance product, 50 GoHealth locations. And then this is a great case study. CityMD, they're only 7 years old, opened in 2010 in the New York, Manhattan area, and they were already competing with Minute Clinic and Dwayne Reed Express Cares, and they got 68 sites open. They got to a decent size, not so bad, 15, 20 sites. The venture capitalists started to take note, and they got a valuation of $600 million. It's just a bunch of, I know the guy, it's just a bunch of guys and gals that were entrepreneurial, willing to take some risks. They're not doing anything clinically that everybody in this room doesn't do on a regular basis in their fast track. So what are some of the trends? Walk-in service. It's very different than an ED. I think some of us take pride. I work in a very resource-challenged environment. Some of us take a lot of pride in that. It's the opposite. Think Starbucks, restoration hardware, Bloomingdale's type experience. Walk-in service, street appeal. I visited an urgent care recently where I had to drive into a parking garage and go around or up 4 levels to then enter the urgent care. It was pretty quiet inside. My buddy's urgent care that has a sign that projects onto the highway and a discount coupon for Chick-fil-A next door is on a busy main thoroughfare with a clear view right from the street with obvious ample parking right in front. He sees 42 patients a day. You have to pick a great location and think retail. Not you can't, must be. The biggest mistake I see is not on the ground level. How do you take sick people and make them go upstairs? It's the stupidest thing I've ever seen. MD, who staffs this? How many use a PA in an urgent care setting now? It's very common, PA, NP. But some of the urgent cares that are owned and operated by individual entrepreneurial ER docs take care of shoulder dislocations, do chest pain workups, and you get a board-certified ER physician there. Open 10 hours a day, 7 days a week. It's hard work. I understand that patients are lower acuity, so there's not the stress of what I call the SAT chorus when you're trying to intubate and kind of struggling a little bit. You're beep, beep, beep. You don't have any of that, but you really need to move the patients, and they have very high expectations. Private exam rooms, beautiful lobbies, coffee service, and you are now responsible for manpower. How many have some challenges? There are a lot of physician leaders in this room managing the docs in their group, just getting everyone to agree and show up on time. Yeah. How many have a little bit more of a challenge managing the mid-level providers in their group? Well, now expand that to dozens of FTEs, and you've got a receptionist, you've got maybe a phlebotomist, you've got an x-ray tech. So you need to get comfortable in a personnel management role. And if you're going to have a successful urgent care, doors open to everybody. Can't be, we don't take care of pediatrics, got to take care of everybody. Digital x-rays, labs, and we'll go through some of the clinical processes. The really, really streamlined urgent cares, digital x-ray, lab, could be just point of care testing, and you can send a patient out for a CAT scan, and then they come back with the reading if that's required. Very, very easy. And there are something called urgency centers that often will now have cross-sectional imaging that they lease the equipment for as part of their setup. They're still not full emergency departments, and in the appendix, I've got some information about that. So the insurance companies, urgent care, friend or foe? Kind of friend. And it's that ED facility fee that is now getting the eyes of the insurance companies. They didn't realize this in the beginning. They thought, that's just more places for the patients to get care. Let's not recognize them. Let's not give them an obvious place of service. Let's make people get a referral. Now the pendulum has swung. Low-cost alternative, not because we, the docs, are so expensive. We're not. It's because of that hospital facility fee that relates to, again, I can take care of anyone with anything at any time. Or, no, I am the specialty that now focuses on the lowest acuity presentation. So your contracts now become key. And we're seeing more and more contracts that are basically case rates or global rates. I would describe a case rate as your level doesn't matter. Level 1, 2, 3, 4, 5, whatever it is, I get $110. And then I bill for my IV fluid, my crutches, my point of care CBC, or a global, I get $175. Doesn't matter what you do. And that's your single fee. Celtic, Aetna, Blue Cross Blue Shield, Humana, all participating in varied and diverse markets with case rates and global rates. And again, I mentioned the volume issue. For reference, since I'm a reimbursement guy, here are the RVUs associated with the urgent care visits. So on the left side of your slide, those are the emergency department codes, 99281 through 99285 that we've been talking about. Most urgent care cases would fit into a level 3 or level 4, 1.75 or 3.32 RVUs. It's an entirely different code set when you move over to the urgent care. They use the office visit code set. And unlike in the ED, it now matters if the patient is brand new, I'm seeing them for the first time, or if I've seen them in the last 3 years, they are now an established patient. And look at what happens to the RVU. So I take my 99283, my ankle sprain in the ED, I'm at 1.75 RVUs. I open up my brand new urgent care, so all the patients are new, 99203, I'm 2.17 RVUs. I've gotten a little bit of an elevation because I have more practice expense. I'm now paying for the building and the overhead and the supplies. But now that patient comes back with their flu 3 weeks later, 6 months later, anytime in the next 3 years, and my 99213, the RVUs have gone down, 1.45 RVUs. And there's some complexities related to the coding between new and established patients that if anybody is really interested in rolling up their sleeves on urgent care, that's an important area, probably the most important area to pay attention to after volume and your contracted rates. And it's actually very important to try and contract because that's what helps to build the volume. That ankle sprain flows, it comes out of your fast track, it goes to your urgent care, it works well the first time, but once they're an established patient, if the coding isn't correct, you can see a real decrement in RVUs. Successful urgent cares breed repeat visits. So over time, a short period of time, the vast majority of patients end up established patients. It's outside of the scope of this lecture, but there are benchmarks for the coding for the new and established patients, if folks want to discuss that. Now, in the urgent care, we get to bill for all the stuff if we're physicians and we own it. The labs, the durable medical equipment, the crutches, the x-rays, both the professional side and the tech. Yeah, you get to bill for your own x-rays. Isn't that nice? You own the pizza shop now. EKGs, point of care testing, medications. But if you have a global, you want to be cognizant of, well, let's see, I get $175 to treat that patient. I'm just like the hospital with a bundled payment for observation. So I want to be thoughtful, both sort of blending the patient needs, patient always comes first, with the economics of all the resources that go into things. So some financial impact issues. The number one take-home point is you got to set up your urgent care so it sees the right volume. That means in the right neighborhood and with plenty of good contracts so the patient comes. We need street-level retail-like appeal. Minute Clinic, they have minimal cannibalization. They don't seem to impact it too much. If you open up and run a decent urgent care near your emergency department, all of your lower acuity patients will leave that ED. We've seen it dozens of times. Seen a 50,000 visit ED lose 10,000 patients. They all go to the urgent care. So what happens to that ED? Have to cut staffing. So if you're ending up being forced by your hospital to open an urgent care, you'll want it ideally 5 miles or more away, or you're taking your own patients. If you know you're going to be taking your own patients because it's only a mile down the road and there's signage right on your hospital campus directing people to the urgent care, there's a harsh reality. We're going to have less patients, so much so we might have to cut staffing over time. Location is key. So it's not like the laceration process. Determines payer mix and foot traffic. And then urgent cares have very significant cyclical issues. So out-of-towners are very likely to simply Google urgent care or Minute Clinic. So if you're in an area that has high proportion of vacationers, you're in South Florida and you have a bunch of snowbirds that come down, that will drastically influence your volume. That means it influences your profitability. but it's also your cost. You have to hire to cover that surge in volume. And we're not talking about, oh, it's a busy Monday, we're going to suffer through. It's a busy 3 months, but I don't want to carry that cost during the down period during the summer. So that becomes a little bit more complicated. What are the expenses? On the left side of your slide, these are the startup expenses. They're $700,000-$800,000, plus or minus a Chick-fil-A thrown in. 3 to 6 month ramp up, build out the space, buy the equipment, recruit personnel, and then legal, accounting, billing, $700,000-$800,000. Ongoing expenses, rent, payroll, and then MD, nurse, tech. The great thing is to have what we call an exceptionist, a person who can greet the patients, get them registered, draw blood, and push the button on and is certified for the x-ray machine. And then who gives the meds? The doc. You can do this with 2 people. Now, you can't do it 45 visits a day with 2 people, but you can do it in the beginning, 25 patients a day with just 2 people. And then one thing that a lot of us forget when we're looking at urgent cares is that $800,000 that we spent, that's debt service. That goes into our operating expenses, and that's why it takes 2 or 3 years to break even. But there are a lot of neighborhoods still available where a good urgent care with good contracts that's delivering high quality with a good retail street appeal can be very busy. Reasonable acuity, typical services I mentioned, x-ray lab, IV medications, NEBs. I've talked a lot about the global contracts. We're seeing global contracts in the range of $150 to $175 a patient. And let's go through the math that illustrates why volume is so important. Typical site, $110 a patient. I'm open 312 days a year. This is real data. 6 days a week, 52 weeks. You can't close your urgent care for a week and expect the patients to be there a month later. So it's 52 weeks out, just like an ED. 25 patients a day, $110 a patient. I have $858,000 a year. I have like a little bit of profit. I might have $58,000 in profit because it's cost me about, with the debt service, year 2, year 3, it's costing me about $800,000 a year to operate it. I have very few variable costs going from 25 patients to 40 patients. All I have is revenue that drops from the top line to the bottom line. I've got the same staff, the same digital x-ray equipment, the same point of care testing. Maybe like malpractice insurance is a minimal variable cost. And look at that revenue, $1.3 million. And that's why at 40 patients a day, and that's 40 to 50 patients, is the average volume of the vignette that I showed in the beginning. And that's why there's $15 million being offered to buy those urgent cares. We're going to spend the last couple of minutes talking about freestanding emergency departments. This has been a big trend in emergency medicine. There is a lot of regulatory action going on here. This is a really big entrepreneurial jump. So if it's $800,000 to start up in urgent care, it's $5 million to start up a freestanding emergency department. And it's very important to differentiate between a physician-owned freestanding emergency department and a hospital-owned freestanding emergency department. A hospital-owned freestanding emergency department is just like any other emergency department. You just have to transfer the patients if they need to be admitted. It's exactly the same. There's no different rule. It's just like any ER that any of us work in. We just don't have an upstairs to go to. A physician-owned freestanding emergency department is a very special economic beast that lives mostly in Texas and Arizona and a little bit in Colorado, and has a lot of opportunity for profit, but a lot of risk and a very murky regulatory future. 24 physicians staffing 2 hospitals in the Midwest feel very pushed around by their hospital. Contract renewal, a 90-day out, which is very common now, is inserted into the contract. The group is dedicated to the area and wants to open their own freestanding emergency department. They arrange for a $2 million line of credit. They employ everybody, run the whole thing, and anticipated financials year 3 show a several $million profit. And that's about right. If you invest your $5 million on day 0, by year 3, you will actually start to make some money. The problem is the regulatory environment, 1,000 days after you spend your $5 million, is not clear. It's not easy to forecast right now. Some of the coding requirements, CPT definition for use of those all-important 99281 through 99285 codes, organized hospital-based, owned and operated by a hospital under a hospital license for provision of unscheduled care, needs to be open 24 hours a day. If you fail that definition, you're really not an emergency department by the definition of CPT. You're now an urgent care. The important thing from a revenue perspective for the freestanding emergency departments, in particular the physician-owned, is the ability to generate the thing the insurance companies don't like. It's the big facility fee. That's where all of the margin is. And it's interesting. We talked about the anyone with anything at any time, and we can deliver a breech baby and do a postmortem C-section and take care of appendicitis. The freestanding emergency departments, many of them have minimal or no ambulance traffic, so they're taking the lower acuity but still moderately sick patients. Those are very high profit margin, very high. Freestanding ED clinical capabilities, I've got them listed here. Accepts EMS, CAT scan, MRI potentially, ultrasound, labs. So it sounds like a good deal. Anybody here, I'm willing to risk my $5 million. Let's all go in together and get an emergency department opened. I'm really tired of the hospital. I'm feeling burnt out. I want to be master of my own destiny. Well, the problem is you can't do it just any place. You need to overcome what's called the certificate of need requirements, and they may be softened. The current administration, which is sort of deregulating a lot of stuff, is talking about rolling back some of the CON requirements, but right now it's impossible, almost unheard of, for an independent physician group to overcome and get CON approval for an emergency. It's in fact never happened. For an independent physician group in a certificate of need state, we would not be successful. The CON process goes all the way back to the 70s, and it was a cost control measure. If we build 100 hospitals in a small state, and then add 100 more hospitals, the state is going to have to subsidize all the hospitals. So they decided, you know what, we're going to set up a bunch of regulations that determine the number of complex medical facilities that can be built out. I live and work in the Mid-Atlantic area. At one point, we had a little friction, maybe it's happened to you, with our hospital. And I thought, you know what, let me test the waters. Maybe we'll just build our own hospital and see what happens. And we got organized, and getting investors actually wasn't hard. The CON process, we brought in a consultant. It was going to be about $2.5 million to go through the CON process with an estimated chance of success of 8%. So we didn't do it. If you're in a non-CON state, and there are some, then that big facility fee, instead of an urgent care, which is 25 patients to break even, now you only need 12 patients, and some of them as few as 10 patients a day to break even. So I mentioned the CON and what some of the state-level regulations are. They're here for reference. I'll go through, this is the way the CON process works. I'll use Michigan as an example. This is right out of the Michigan regs. Except as otherwise provided, a person shall not do any of the following without first obtaining a certificate of need. Provide 24-hour emergency care. So I can't, in Michigan, I can't just go open a hospital, but I can open an emergency department in a state that doesn't have a certificate of need. The question is, will the private payers, Aetna, Cigna, United Healthcare, Blue Cross, pay my big facility fee? Right now, yes. In the future, maybe. And I would say the trend is slightly negative. The guys who I've spoken, and gals, who own 5 or 10 or 15 freestanding emergency departments in Arizona, Texas, Colorado, they are looking to now move away from this concept of, well, we don't participate in Medicare, we don't participate in Medicaid. Let's mature as an industry and actually be recognized for what we are, which is something a little bit less than a level 1 trauma center, but more than an urgent care, and maybe have a lower but recognized and regulated facility fee. And so that may come. Here are some of the Medicare conditions of participation, and a physician-owned freestanding emergency department doesn't meet any of these. So that's why it's very, very tough. Now, what if your hospital comes to you and says, we're going to open a freestanding emergency department out in the suburbs, and we want you guys to staff it? Well, I don't know, I heard that's really complicated, there's a lot of controversy. There's not. That is a hospital-owned freestanding emergency department. They can be wonderfully successful. You need volume in order to keep the doors open. 16,000 visits is about the sweet spot where a typical ED can operate in a freestanding environment owned by the hospital, where all we're billing is the physician component, 99281 through 99285, a little critical care in our procedures. About 16,000 visits, we don't need a hospital stipend. The sweet spot, 21,000 visits, I can use single MD coverage and then have some profit margin over mid-level providers that are seeing the lower acuity patients and doing some of the procedures. So that can be a winner. Really important, just circling back, hospital-owned freestanding emergency department, it's just a smaller emergency department. Everything else is just like all of the EDs that all of us work in. So there's been a huge proliferation of freestanding EDs, both hospital-owned and physician-owned. I went through some of the math here and some of the economics. The facility collections can be 2.4 to 4 times the pro side. They can be several $1,000s per patient. And some of these freestanding emergency departments currently run little observation units and get the patients pre-certified. That can be $3,000, $4,000, or $5,000 per patient. But healthcare reform, state reform, and the guarantee of that facility revenue is a little bit up in the air. Here's the current temperature on the overall freestanding emergency department industry. Texas, Association of Freestanding EDs, 20 companies at over 70 sites. There's a freestanding emergency department at almost, if you go to the Dallas-Fort Worth Metroplex area, every Chick-fil-A has a freestanding emergency department next to it, 100%. Neighbors Healthcare, you can actually buy a share in the company. It's an owner-operated process. They have had a booth at Scientific Assembly for the last couple of years. So I live in Virginia. I'm going to buy a share in Neighbors Healthcare, and I'm going to agree to go out to rural Texas and do shifts 3 times a month. And folks are doing it. Sounds a little bit like sort of the frothy tulip phase of the market, but nonetheless, it's out there. One of the original freestanding emergency department groups, physician-owned, had a successful IPO. They then grew really, really quickly. They were a victim of their own success. Hub and spoke model in Arizona. This is published data because they were public. $1,450 per patient visit, pro and facility. They were profitable at 9.8 patient visits a day. I don't think it projects all that well. Their stock price, they went public at about 10 or 12 bucks. They peaked at 10 times that amount several months later at $120, and they are out of business already. Out of business. They grew a little bit too fast. It's a complicated industry. So the future, increased state regulation. 16 states have laws for freestanding EDs with varying requirements. There are some states where the CON process is just lax enough that if you had the fortitude, about $5 million to start it up, you'd have to feel like you had about 1,000 days, about 3 years of runway to get your break even, but then it can be very, very profitable over time. Putting that together with the mission of both the Specialty and the ED Benchmarking Alliance, combination of urgent care or freestanding emergency department, we are more than a room or a department. We're the masters of acute care. We need to own these patients and these spaces wherever they are. Urgent care with volume, 25 patients a day. Demographics and good contracts can be very profitable. And then independent freestanding ED, big CON barriers. And if you're willing to take that risk, you need to feel comfortable about the regulatory environment for 3 to 4 years to come.